Welcome back. I am excited to introduce you all to our next speaker. Dr. Jacob Schulz is an assistant professor of pediatrics and orthopedic surgery at the Children's Hospital at Montefiore. He is director of the Pediatric Orthopedic Surgery Fellowship and co-director of Pediatric Orthopedic Research. After medical school at the University of Pittsburgh, he completed his residency at Albert Einstein Medical Center in Philadelphia and completed his fellowship in pediatric orthopedic surgery at Rand Children's Hospital in San Diego. His clinical and research interests include spinal and limb deformities in children and adolescents. With that, Dr. Schulz, I'll let you take it away.
Great. Thank you so much, Elise. And really thank you to the MDA organization for inviting me to speak today, and to my fellow presenters. Dr. Delfiner and Dr. Braylon gave wonderful talks earlier, and I hope I can build on that. And I look forward to your questions at the end. So this talk, as the title implies, is about when should or possibly shouldn't your child have orthopedic surgery. And obviously this is more focused around children, but if there are patients who are older, past skeletal maturity, some of these same issues apply as well. So the outline of the talk today, I'm going to touch on 4 basic topics. And the first thing to think about is collaboration. I think Dr. Delfiner did a fantastic job of going into this earlier. But the way we work together as a team is really important in order to maximize the care that we give to our patients, especially patients with as complex a medical history as those with muscle disease. And so I think taking a few minutes to really emphasize this and go over it will be helpful. Then we're going to talk about fractures, which we commonly see in children with muscle disease, and how we manage them, the ways we use casting or bracing or surgery. Then we'll go through some about contractures, the ways that they develop, and how we can treat them. And finally, we'll end with some talks on scoliosis and best practice of management there. So first, for collaboration, I think there are 3 rules of collaboration. And the first rule is there are no rules, right? There are best practices, however, and Dr. Delfiner did a really nice job of going into this, and that we have a lot of guidelines for certain specific diseases, and these are best practices. And in some instances, they are guided by very high evidence, what we think of as level 1 evidence, where we have randomized groups of patients. And we give them specific interventions and see the result. But often there aren't those kinds of perfect randomized controlled studies for a lot of these diseases that the patients present to the muscle disease clinic with. And so every patient is unique, right? Even patients within the same disease diagnosis may have very different symptoms, very different needs. And so we follow the best practices and we use our clinical judgment, but there are no specific rules. Rule number 2, though, is transparency. And this works both ways. And I always encourage patients to ask questions, to write down their questions before they come so that they are prepared to ask them. Because when you're sitting in a doctor's office with someone that you may not know as well, when you come to see me as a specialist, I may not have the same longitudinal interaction with you or length of interaction with you that Dr. Delfiner does, say, or Dr. Braylon. And so I think writing down your questions beforehand can be really important. And honesty on both sides of the coin is really another key. You should feel free to be honest with you about your symptoms. And we should encourage you to be honest about your symptoms, whatever they may be, and how the disease is affecting you and your family. And we should be honest about what we can and cannot accomplish with either medical management or surgical management. Last is teamwork. And so I put a few of the buzzwords or buzz phrases there. It takes the village. Let's play in the sandbox. There's no I in team. But this is really key. And I feel like at Montefiore and the Children's Hospital, we've developed a really great cross-collaborative team where we're able to communicate with each other. We may not always be in the same place, but we always try and work together and achieve the best outcomes for our patients. Along with collaboration, and this I think dovetails with Dr. Braylon's talk, diagnosis. Often some of these diseases, it's very tricky to diagnose. And it seems like every time I look in the medical literature, there's new testing available and new information available about specific of these rare diseases. And so I think it is important to have a diagnosis, but obviously the discussion about genetic testing and things like that are very personal for families, and no one should feel that they are required to have genetic testing if they're not comfortable. But obtaining an accurate and specific diagnosis will allow us, both for your child and going forward for all children with this disease, to have a better understanding of the natural history. Diagnosis is usually a combination of clinical examination and laboratory examination. Dr. Braylon really went into that very well for the genetic component. But occasionally surgery may be necessary, and this is the first time in the talk where we're going to say that, hey, this is a possibility for surgery for your child. I think it's becoming less frequent, but on occasion I have done muscle biopsy where the exact disease was unclear, and that pathologic examination of muscle tissue may be a helpful component of that. But as I said, that is becoming less common, I would say, as the genetic testing and other testing becomes more accurate. And to emphasize again the importance of data. When you have rare diseases, as some muscle diseases may be, you really want to get a good cross-section of data, of population data, to understand what is the natural history of the disease untreated. Duchenne's is a classic example of a disease where we really understand a lot of it because we have good natural history data for a long period of time, and we have data before and after certain medical interventions like steroids have been implemented. And so with that information, then we can give better guidance to families as to what is and is not appropriate care. So I think that this all comes back to trying to get as accurate a diagnosis as possible, given the limitations of the medical field at the time. Collaboration with families. Families and patients know way more, and this is specifically about children, but families know way more about their children than we do, right? You see your kids, or you see yourself on a day-to-day, hourly basis, right? And you know how you're feeling, how you're functioning, what you may or may not need. And so we may have a lot of information from a general standpoint about your disease and about what can be helpful, but you have a lot of specific information about yourself, and really being an integral part of your own care and an advocate for yourself and for your children is vitally important. And along with that, shared decision-making. We have lots of complex conversations about disease management and the possibility of certain medications or surgeries on my part. And having a collaborative decision-making is paramount to achieving a successful outcome. I take care of a lot of children with spinal deformities, and I just had a long conversation the other day. Unfortunately, it had to be over a telephone call because of COVID and because families are far away, about how just because your child has a severe scoliosis that could benefit from surgery doesn't mean that surgery is necessarily the right choice for you and your child. And it can be hard to make that decision, but I think when you have effective communication between the provider and the families, the social workers, the therapists, that's really where you get the best outcome. And just to emphasize again, when you're not sure about something, ask for help, ask questions. I think one of the misconceptions about medicine is that we sort of have all of this information and know all of the answers, and we just sort of give you the information and give you the treatments. And that's almost never the case, right? The case is that this is a team effort, and we need your support for it, and you need ours. But ask for help and advocate for yourself. And we are here to answer all the questions that we can, and to say that when we don't know the right answer or a perfect answer, and how do we come to the best possible answer. And I think that gets back to the best practices idea, right? There's no perfect practice. There's just the best practices, and these are guidelines and roadmaps. So collaboration here at the Children's Hospital at Montefiore, and this is certainly not an exhaustive list, and Dr. Delfiner showed it as well, but I really have to thank all of my colleagues in all of these departments for their great care and their help in educating me on a lot of these diseases that affect kids with neuromuscular disease, and how we can best manage them. Obviously neurology and genetics are right at the top of this list, but pulmonology and cardiology play huge roles in maximizing the safety and the health of our patients. From my standpoint, to maximize their health pre and post surgery. The physical medicine and rehabilitation department overlaps a lot with what I do. They don't do surgery, but they may do interventions like Botox for specific conditions, and really help kind of maximize bracing and therapy. Having a great physical therapist, and I'll come back to this a few times, but having someone that you have a relationship with and can work with, because motion is life. And the more we can keep our children and ourselves active and moving, will really prevent a lot of the complications that we see with disease down the road. Endocrinology, another team I want to emphasize, maximizing bone health and hormonal balance is really key for a lot of these. And the last, Dr. Delfiner also mentioned this, the Quality Impact and Life team, or palliative care. We have a fantastic group at CHAM with this, and it's really about maximizing a patient and a family's goals and joy, not just in their medical care, because there will be so many medical appointments, but how do you balance that with your life and what your wants and needs and wishes are. And that palliative care team really helps to bring what's really important in your life into focus. And what's really important in your life may not be the braces that you wear or the steroids that you take. It may be the trips that you want to go on, or the games that you want to play. And so I think all of these services play a role, but I think that palliative care team really kind of rounds out and impacts on all of the rest of the care. Now we're going to move specifically into a few different topics. And the first will be fractures. This is obviously one of the most common things and basic things that we treat as orthopedic surgeons. We deal with bones. And just to start simply, and this obviously may be oversimplified for many of you, but a fracture or break or broken, these are all the same thing. I can't tell you the number of patients who ask me, is it fractured or is it broken? And it's the same. But it's easy to get confused sometimes because of all the terminology that we use. Importantly, when children have fractures, the first thing is diagnosis. And sometimes that diagnosis can be less clear. Sometimes because of the underlying disease, there may be issues with sensation. And so, a limb may look swollen, but the child may have no pain. Or sometimes the child may have a lot of pain. We think there is a fracture, but there's not. And so x-rays are the definitive way to diagnose a fracture. Sometimes things like CT scan or MRI may also be helpful. Fractures can be displaced or undisplaced. So I like to say that undisplaced fractures are like if you're driving a car and a rock hits your windshield, and the windshield splinters a little bit, but it doesn't shatter. And the difference is that the bone will heal itself, unlike your windshield, which needs a glass doctor to replace it. But displaced fractures, on the other hand, are where that rock hits the windshield and the windshield shatters, and then it really needs more intervention to try to get it to heal, not just heal it at all, but to heal in the right position to maximize function. Just like real estate, location, this is important. It's very different to break one a phalange in your pinky toe than it is to break your femur bone. And so where in your body the fracture occurs and where in that bone the fracture occurs can make all the difference in the world as to what the ultimate treatment will be to maximize function. And then specifically for children, and this is what I deal with a lot, is does the fracture involve the growth plate? And how will that affect growth over time? The two most important growth plates that are affected by fractures and that we have to intervene with are the growth plates at the end of the femur bone, just above your knee joint, and the growth plate at the top of your tibia bone, just below the knee joint. Because these two growth plates provide the most longitudinal growth or length growth for your legs throughout life. And if fractures involve these growth plates, or if injuries or infections involve these growth plates, that can really affect the length of a leg and create a difference between those two. And so we have to follow those closely. The X-ray here is an example of a tibia fracture. This is the bone between your knee and your ankle. And we'll get back to it in a little bit, how it specifically can be treated. Fractures are always the result of trauma. You cannot break a bone by just sitting in a chair and doing nothing. However, trauma is a broad term. Right? Trauma can be, falling off a bridge, or trauma can be falling from your chair onto the floor. A sort of a nothing event that we would think, oh, how could that possibly cause a fracture? But in the wrong patient at the wrong time, it really can. Trauma and fractures are more likely, and trauma is more likely when strength and balance are impaired. And those things are impaired by the disease itself, by the disuse that may result from the disease, by not having as much interaction with therapists and proper medical care and medical treatment. And so far less trauma is needed when the bone is already weak. When the bone, we think of the bone being weak, the medical terms are osteopenic or osteoporotic, really having holes in it and being incredibly weak. And how we diagnose that element of bone weakness is a little bit up for debate, but x-rays can be helpful to show kind of globally what the bone looks like, or specific tests like DEXA scans, bone mineral density scans, to try and determine the amount of bone mineral density that you have and trying to predict what your fracture risk is. So once again, that the weakness and imbalance can be due to underlying disease. Treatments for that disease. We know that steroids are very helpful for certain diseases, but that steroids can also have some unfortunate risks, and one of those can be weakening bone. Activity level plays a role, and nutrition plays a huge role, and we'll touch on this more as we go along. But for fractures, prevention is key. All right, and so we want to optimize strength and balance and home safety and caregiver understanding and recognition of what they should and shouldn't be doing in terms of moving kids and how to move kids safely using appropriate medical equipment. Home safety is one of those big things where I think it can make a huge difference not having rugs in the house for certain kids, and making your environment around you more stable so that you're less likely to fall. Optimizing strength is hard. When you have progressive muscle disease, the disease itself is so powerful that you can do all the exercise in the world and you're still going to be a little bit behind. But exercise is the only way that we really know to improve strength. And so the more and the better exercise we can do really helps. And so that's really where physical therapy, having a structured physical therapy program, a collaborative intervention or collaborative care team can really be of paramount importance. I mentioned here pharmacologic or nutraceutical interventions to improve bone quality and minimize fractures. As I said, steroids can weaken bone, and so certain drugs like bisphosphonates may, in the right child, help to reverse some of those effects and improve bone health so that you're less likely, if there is a fall, to have a fracture. Nutraceuticals are something that people find very appealing because the idea is that they're relatively natural and can help with your body to optimize bone health. I always advise some caution in that because there are a lot of claims out there that are not supported by the FDA or by great data in terms of different vitamins and minerals that are supposed to support bone health. And often they're not dangerous, although sometimes certainly there can be some danger involved, but they can be very expensive and may not be covered by insurance. And so before families go down the path of buying all of these different vitamins that have very little data, I think it's important to have a real frank conversation with your care team, your pediatrician, your neurologist, your orthopedic surgeon even, although I will admit that we're maybe not the best with medical management. And so trying to maximize the benefit but minimize the risks and cost is certainly a risk, as has been touched on in a few of the other talks. In terms of treatment, not all fractures need surgery, and most fractures that I treat in general don't need surgery. Casting or bracing is all that's required, but surgery can be very beneficial in certain situations. So these are two examples of different fractures, and this is the tibia fracture that I showed before. And this is a young man with Duchenne's muscular dystrophy, minimally ambulatory at this point, mostly in a wheelchair and weak, but this is a weight-bearing bone. And so we certainly don't want to prolong immobilization in someone and create more weakness, more osteopenia of the bone. I always give the example that when astronauts go into space, just the lack of gravity acting upon them causes severe osteopenia unless they are really working on interventions such as exercise and strength training in space to minimize that. And so as someone who sits in a wheelchair most of the time, in some ways that's like being in space. Gravity is still there, but the typical muscular forces on your bone and the typical weight-bearing forces on your bone are not the same. And so it's much easier to get a fracture in that situation. So this young man sustained a fracture in what's called the midshaft or the diaphysis of his tibia. And you can see one of the early x-rays there on the left. There's probably already a little bit of healing. It is a little bit displaced and angulated, right? The bone is not as perfectly straight as it was before, but the bone next to it, the fibula, is intact, and that provides a lot of support. And as I said before, this child is non-ambulatory at this point. He's mostly in a wheelchair. And so in this situation, while surgery could be considered to stabilize the bone, I think a cast is really the perfect management. And even in a child who is ambulatory, you can often walk in a cast. And so the x-ray that's shown on the right is taken about a month and a half later. And you can still see the fracture that's there, but there's much more a callus or new bone developing between the two segments of bone, indicating significant healing. And once we see that those bridging callus and bone on three sides of the bone on two different views, trying to represent a three-dimensional object in two planes, then we know the fracture is healed. And it's kind of like if you have a river, a fracture is like a river. An earthquake creates a break between Manhattan and Brooklyn, and there's the East River. And in order to heal the fracture, you have to build the Brooklyn Bridge. So the Brooklyn Bridge is built here. This is a different kind of fracture that needed surgery. So this is a femur fracture in another child with Duchenne's muscular dystrophy. And this child was ambulatory to a significant degree. As I emphasized a few times, maintaining ambulation, maintaining function is probably one of the best goals, or the most important goals that we have as providers and people who care for all kids, but especially kids with muscle disease. And so this child had a relatively minor fall. And these fractures can often happen with very little trauma. Just moving a child the wrong way, muscle contractures contribute to abnormal pull on the bone, and you try and force a limb into a different position, it can break easily. But this bone broke once again. It's the femur bone, and it broke in the mid shaft or the diaphysis. And you can see how the bone is angulated. It's not as straight as it should be. Often this can be treated with a cast, and even in older children, 5, 6, 7, 8 years old, who are more don't have muscle disease and are ambulatory, a single leg cast can be a great treatment. There's no metal involved. There's no surgery. However, in a child with Duchenne's or other muscle diseases who is still walking, but we're concerned that at some point the ability to walk may go away, we really want to maximize their ambulatory function and to get them moving as quickly as possible. So a cast for this child could be devastating to their overall function and could really impair them and put them in a wheelchair. And so I think the ability to fix the fracture securely, as the x-ray shows on the right, with what's called an intramedullary nail, or a piece of metal that goes down the bone and holds the two pieces of bone in the right position and holds them steady and stable while they heal, is really a huge benefit for this child. And right away after surgery, you can mobilize the knee, mobilize the hip, and even start some early walking. So this is one of those situations where surgery for fracture can be tremendously beneficial for the patient. Next, we're going to move on to contractures. And this is a very common issue in children with neuromuscular disease. Contractures, can be hard to think about it, but I like to think about loss of joint motion. So your joints all move in specific planes. Your elbow and knee joint sort of move in one plane, forward and back. Your hip joint and your shoulder joint move in 360 degrees all around. And so that joint motion is important for joint health, for cartilage health, and for painless activities. And so the loss of joint motion is stiffness, and you can be stiff for a lot of reasons. But stiffness, true stiffness in a non-functional position is what I think of as a contracture. And so we often think about this around the knee or around the ankle. If your ankle joint was stiff, but your foot was in a flat position where you can put it down on the ground and walk around, then that's stiffness, but I don't think of that so much as a contracture, because that's a functional position for you. You can put your foot down, you can put a brace on it, you can put a shoe on it. But if your ankle is stiff and it's pointed down towards the floor like a ballerina, what we call a quinus, which is a common contracture, that's a true contracture because that's a non-functional position for that joint. And that really limits your ability, even if you had the strength and the balance and the proprioception to walk, that can really limit your ability to walk. So contractures really impair activity and impair care. In the upper extremities, the arms, contractures result in loss of dexterity, and that may mean dexterity in terms of playing a game like playing cards, but more importantly, it can mean loss of dexterity like the ability to feed yourself or to care for yourself in the shower or in the bathroom. And so, minimizing those contractures are important. And for the lower extremity, for the legs, a contracture can result in loss of ambulation, can result in pain around a joint or stiffness. So prevention, an ounce of prevention, we think it's worth a pound of cure. And so physical therapy and regular stretching are by far sort of the most important and safest interventions that we have. But unfortunately, the evidence is really thin for these. And as doctors, we really like to rely on the evidence, but it's not always there. And so I'll make a plug here for anyone, both on the medical side and the patient side. If you can help with any research projects that you possibly get offered, and at least to consider them, it can really help both for your own care and for the care of other children. But I do think that physical therapy and rehabilitation are really the basic treatment modalities that really make a huge difference in the quality of life of children and help to prevent contractures. This is a high reward and low risk treatment. Bracing for contractures. So this is a common one. We have our orthotic colleagues, the people who make the braces. It's really important to have a good orthotist who knows your child and knows the goals of your child and of the care team. And so bracing is slightly higher risk than therapy. Bracing can cause skin issues, but it can be high reward in the right patient. Duchenne's, once again, is better studied among the neuromuscular diseases because we just have more data on it. And in certain kids, daytime bracing to improve the function of a joint, to stabilize an ankle or a knee, can really help. And nighttime bracing, stretching bracing to help prevent contractures can also be beneficial, though once again, the data is limited. I have pictures here of two different kinds of common braces. The one on the left with the skull and crossbones is what's called an ankle-foot orthosis, and it's articulated so it can move up and down with your ankle. Those also can be solid, and there are many different styles there, but that can be worn at daytime or at nighttime to help with ankle motion and stability and help prevent contracture. And the picture on the right is a child with a scoliosis brace or a thoracolumbar support orthosis, and there are many different varieties of these. We use these a lot in kids with scoliosis and spinal deformities that are what are called idiopathic, so no other medical conditions going on. In the setting of neuromuscular disease, the bracing is much more controversial. And I think there can be some benefit in the very early stages of spinal deformity or even before spinal deformity to try and improve posture and things. But there's no good data that says that bracing really reverses the course of these diseases. And in some ways, the braces can be a little bit risky in children with underlying neuromuscular disease because they are constrictive and they may impair pulmonary function sometimes. And so we have to be very cautious about how we use these things. So braces are not the be all and end all sometimes, but are a big part of our armamentarium for treating patients well. And finally, surgery for contractures. So there are things that you have to meet in order to have surgery for contractures. First of all, I think your medical management has to be optimized. If a child comes, I have plenty of patients that come to my office and they have contractures or other issues that may benefit from surgery, but they're not plugged into our muscle disease clinic. They don't have appropriate bracing, they don't have appropriate physical therapy. And so, these things need to really be in place before you consider surgery, because surgery by itself, without the appropriate surrounding care, can often be worse than no surgery. Obviously, there are risks. If the contracture is affecting ambulation or impairing brace wear is severe and causing pain in non-ambulatory children, this is a great reason for surgery. But this is a controversial topic and there's no clear consensus. Once again, there are different surgery types. The simplest surgery for contracture is what's called tendon lengthening. So the classic example of this is a foot that's pointed down or in equinus. And the Achilles tendon, the big tendon that connects your gastrocnemius muscle complex to your calcaneus, that Achilles tendon becomes very contracted or short and tight. And so cutting that tendon either completely or partially can help to restore the normal length tension relationship of the tendon and bring the ankle joint into a better and more functional position. And so that's the simple kind of surgery. And there's also rebalancing surgeries where we move tendons from one bone to another so that they're pulling too hard on one side of the foot. We move them to the opposite side to try and give a more balanced functional approach to the foot. Timing of these surgeries is a really big topic, and some of you may have questions about that, and it's really patient specific. We try not to do these surgeries too early, but at the same time, you don't want to do them too late when contractures are truly set in and you need more work. So there are some best practice guidelines out there on what is the best timing for children, but it's very patient specific. Bone surgeries or osteotomies may also be effective or necessary for severe deformity. Sometimes a foot is so curved and twisted that just cutting the tendons alone won't do enough. And so moving bones around, especially the calcaneus or the bones of the midfoot, in order to put the foot in a more plantigrade or flat position can be very helpful. And around the knee, we also do sometimes, and around the hip, we also do bone surgeries as well to sometimes to reorient the hip joint or to get the knee straighter to maximize the ability to walk. Once again, I can't emphasize this enough. Pre and post-operative mobilization is critical. Having a good physical therapy care team really helps to make me look better as a surgeon. And that's, well, obviously that's not the goal, but the goal is to get your child and you the best care possible. And so getting kids moving quickly after surgery and making sure that everyone is aware of what are the limitations after surgery, what things should you avoid in terms of activity, and what things should you really work on after surgery can really help to get the most benefit. And finally, again, this is still a controversial topic and no clear consensus. Our understanding is always evolving. I didn't mention the slide, but sometimes things like gait analysis, we often use x-rays in clinical exam, but gait analysis is sort of like an x-ray of your gait. It's a picture of how you walk and how well you walk as compared to someone who doesn't have any underlying disease. And so that can be a really helpful piece of information to determine what might be the best surgery or not surgery for your child. Our last big topic here is going to be scoliosis or curvature of the spine. And so scoliosis is defined as a curvature of the spine of more than 10 degrees measured on a frontal upright x-ray. We do like upright x-rays in a weight-bearing position, either standing or sitting, because that's really how the spine is when it's loaded by gravity. X-rays that are done lying down, either on your back or on your belly, can be helpful in some situations, but they don't really give us as much information. So it has to be curvature of more than 10 degrees. Anything less than 10 degrees, we think of as spinal asymmetry, meaning it's not perfectly straight, but it's pretty close. And we see it all the time. Scoliosis is really a three-dimensional issue. We often look at it x-rays, one x-ray from the front, one x-ray from the side, but the spine doesn't just curve in one direction, it curves in all directions. And so the spine rotates as it curves. That creates prominences in the back that you see where the ribs are more prominent on one side than another. And so we have to think about scoliosis in a three-dimensional way. And I think that's doing that more in the last decade or so has really kind of revolutionized scoliosis management. Scoliosis is very common in non-ambulatory children for whatever reason. When you stop walking, often because of weakness, the scoliosis is much more likely to develop. It is far less common in ambulatory children with muscle disease, although we do see it frequently, and I'll show at least one x-ray of that. There are many different curve patterns, and where the curve is where the spine is the most curved can impact different parts of your body, whether it's up in your chest and how that impacts the lungs, or whether it's down by your waist towards your pelvis and how that can impact sitting. Regular exams are very important, and this is true with children with and without muscle disease, but being evaluated by your pediatrician, by your physical therapist, by your neurologist. I'm sure Dr. Delfiner always often communicates with me about kids that she sees that appear to have curved spines and how should we follow them best. So getting a regular clinical exam and then regular x-rays if there's a suspicion of or a known early developing scoliosis. That's the best way to tell what the curve looks like. I see many children who look like they have scoliosis and don't on x-rays, and I see many children who don't look like they have scoliosis and have pretty severe scoliosis on x-rays. And so the way you look clinically may not be a perfect surrogate for the way you look on an x-ray and the way your spine really is working. So this is an x-ray for scoliosis. This is a non-ambulatory child. She actually has a congenital muscular dystrophy, a LAMA2 related. These are the typical x-rays that we get of the spine. So one is a picture from the front, sitting in this situation, and one is a picture from the side. And they're both equally important. We tend to focus on the x-ray from the front, which is the x-ray on the left, where we can, really see her skull very well. But the x-ray on the right, the x-ray on the side, may be just as, if not more important. The way our spine lines up from the side really determines how balanced we are in that plane. And we all, as we get older, tend to kind of fall forward. Life is a kyphosing, or a curving forward event, as one of my mentors used to say. And so we really want to emphasize the importance of not just the view from the front, but the view from the side as well, and the three-dimensional appearance of it. I don't know if you can see it on the slide, but there's a number on that left x-ray, the frontal x-ray, the 98.2, and that's the degrees of that curvature. So the spine should be straight, that number should be 0. The way we measure that is we draw a line at the bottom, the most curved or tilted vertebrae, vertebral body at the bottom of the curve, and then another line at the most tilted vertebrae at the top of the curve. And the angle that's subtended between those two lines is what's called the Cobb angle, and that's a number that you'll always hear when you go to your doctor and see these and get X-rays. And so I think that is important to know what that means, that Cobb angle. It's not a percentage, it's an angle. So, your spine should have a 0 angle. This is a 98-degree angle. That's a really big one. And that clearly needs intervention. So what are the problems with scoliosis? Mild scoliosis is very well tolerated in almost all people, although certainly muscular disease may be a little bit different there. But the problems of scoliosis are deformity, the way that you look, the way your spine looks and feels. Pain can be associated with scoliosis, although this is a little bit of a controversial topic. The most well-known, well-studied population with scoliosis are what's called the idiopathic, the kids who don't have other underlying diseases. And a lot of teenagers will have back pain regardless of scoliosis, but probably with scoliosis they have a little bit more. And in the long term, having severe scoliosis does correspond with pain. Skin issues and seating issues are really big, and I have a clinical picture here of a young woman with severe scoliosis. And when the spine is so curved, as we saw on that last X-ray, and the ribs can really almost touch or sit on the pelvis, and that can hurt, and that can make it harder to clean that area, if you're being cared for, and that can result in skin issues like this ulceration that you see there. I know it's not necessarily pleasant to look at, but this is the kind of thing that we're trying to avoid. And so surgery is a way surgery can be a beneficial way to do that. And so being on top of the scoliosis management is of critical importance. Pulmonary issues, likewise, are really manifest in scoliosis and in muscle disease in general. We like to think that if we correct scoliosis, if we make the spine straighter, that will really improve the lungs. Unfortunately, the data there is less clear. But at the very least, it does seem to help prevent worsening of lung function in a lot of situations. And then having severe scoliosis can really result in problems with care, with positioning, with seating in your chair, with ulcers on your butt when you sit, and with cleaning the skin, as I mentioned. So treatments for scoliosis. There are really two basic treatments for scoliosis. The third sort of category of treatment I don't specifically mention here, but I'll talk about right now, is therapy. For certain populations, it's become very popular to try and work on therapies, scoliosis-specific exercises to improve scoliosis, and the data is limited. But so I don't know if that's a great treatment for scoliosis in the neuromuscular disease population, but certainly therapy is an important part of your overall care pathway, and should be implemented. But for scoliosis in particular, bracing. So bracing is very effective in the right patient with idiopathic scoliosis, but not clearly effective in preventing preventing progression of scoliosis in muscle disease or neuromuscular disease. And as I mentioned before, bracing can sometimes compromise pulmonary function, so we have to be really cautious about the kids who we think could benefit from bracing. But I do see a lot of patients who are in wheelchairs with neuromuscular disease who may benefit from soft bracing, really to help with positioning in their chair. So in addition to making the chair as good as possible, the brace can be another way to improve their sitting posture. So there are a couple things to think about with surgery, which is the other main treatment, is the who, what, when, where, and how. And so those will be my last few slides here on scoliosis. So the who. So kids who are walking with curves over 50 degrees, those are kind of the basic general population that we think about surgery, because we know that when curves are that size, even if you have no other underlying disease, that curve will almost certainly get worse over time. And that's just a biomechanical relationship. If your curve is more than 50 degrees, living your life, gravity acting upon you, that curve will get worse. And so intervening earlier can be really beneficial. For kids who sit, who are in wheelchairs, then progressive curves more than 25 degrees, so a much lower cutoff for when we intervene with surgery. But this is a general guideline. Some kids will have 30-degree curves during wheelchairs, but they're doing great and their curve is stable. They're comfortable. That's one that we would just watch. And watching is not a non-treatment. Watching is more sort of an active intervention, making sure that curve doesn't get worse. There is some pulmonary guidance or best practices for scoliosis, and having good pulmonary function testing is really important, and prehab is really important. The forced vital capacity, the amount of air that you can push out of your lungs in a test, if that's less than 50% of the expected for your age, that might be a reason to consider surgery earlier, because if that declines, it's going to increase your risk. And those with a forced vital capacity of less than 30% of predicted seem to be at higher risk of pulmonary complications, longer intubation, difficulty with extubation after surgery. But interventions like BiPAP after surgery or prehab before surgery can really improve those risk profiles. So what is scoliosis surgery? The most common, this is a fusion surgery. So we take a spine that's very curved, somewhat flexible, and make it straighter, but very stiff. That's a trade-off. I mean, I wish I could make the spine straight without compromising flexibility, but that is not yet truly possible in the vast majority of cases. So it is a trade-off, and it's important to understand what that means for your child and for their long-term spine health. There are newer treatments for younger children that are still growing that involve guiding their growth with the hope to preserve length of the trunk for proper lung development and lung function. And so these are nice, and I'll mention at least one of those. When should surgery be done? We would like to wait until growth is complete, because then we don't have to worry about growth and some of the issues that can come along with further growth after a spine fusion, but that's not always possible. We also prefer not to operate on ambulatory children. If this is data from the Duchenne's population, if kids are walking, the risk is that if you do this big surgery, that's a big hit. And that can be the impetus to then not be walking as much afterwards. And so we don't like to operate on ambulatory children, even if they have scoliosis that may benefit from it at that time. And then also we prefer not to operate on very severe curves. So once we see that the curve is heading in a bad trajectory, it's probably better to proceed with surgery sooner rather than later, because the bigger the curve gets, like that first x-ray I showed, the harder the surgery is, the less likely it is to be quite as effective. So an ounce of prevention again. Where? Obviously CHAM is where you should have your surgery, but that's obviously a joke. But I think it's important, just like we talk about these muscle disease centers, to be at a place, an institution where it's an academic hospital, there's research going on, and all the available services are there. Surgery does not happen in a vacuum, and especially scoliosis surgery is very reliant on appropriate pre, intra, and post-operative care. And so you want to be at a place that maximizes all of those things. I think we do that very well at CHAM. But that's, those are the kinds of questions you should be asking. The surgery itself is the same no matter who does it, where it's done, but the care that's provided around that can be very different at a children's hospital versus a community hospital, which is not to denigrate community hospitals at all, just that they don't always have the same resources. How should it be done? The surgery should be done carefully. We do lots of things to minimize the risks of surgery: preoperative optimization, nutritionally, rehab-wise. Anesthesia concerns, things like rhabdomyolysis because of the wrong anesthetics, or malignant hyperthermia, obviously are concerns. Pulmonary concerns. Post-operative care, I mentioned BiPAP. pulmonary issues can be minimized by the appropriate use of pressure ventilation support after surgery. Blood loss limiting techniques, it's very common to need a transfusion after this big surgery where there's bleeding. And so we give medicines that minimize the risk of bleeding during the surgery. And so often we use a technique called cell saver, where during the surgery, the bleeding that occurs, we take that blood and recycle it cleanly and can give it back to minimize the risk of needing a transfusion from someone else. Infection control. Infection is a huge concern in scoliosis surgery. So different antibiotics that we use, the materials that we use for surgery, often having a plastic surgeon to help with closure of the surgery to minimize tension on the skin. And then intraoperative things like navigation and neuromonitoring to help make sure we are as safe as possible with surgery. So these are a couple examples of scoliosis surgery. This is the growing example that I mentioned. This is a growing rod, a type of growing rod that was implanted in this child with neuromuscular disease. And this is a newer device where it's magnetically controlled lengthening device. And so these two rods are put in, and there's a small fusion at the top of the spine and at the bottom of the spine. And the rods in between, they're thicker, as you can see on that x-ray, and that thickness represents a small motor and a magnet. And so an external magnet interacts with that internal magnet, and every few months we lengthen these rods, and that stretches the spine, kind of grows the spine. And so this is a child where we didn't want to do an early fusion. We want to wait as long as possible, but their spine is still very curved, 80 degrees. And so these growing devices can really help to maximize function, height, length of the thoracic column. This is scoliosis surgery done in a growing, but walking, done growing, but they're a walking child. This child has myotonic muscular dystrophy and has an over 60-degree curve and is very imbalanced, both from the front and from the side. And so surgery, as shown on the right, fusion surgery really helps to balance the spine to minimize the risk of progression and let the child be as functional as possible. And then finally, probably the most common scoliosis surgery that we do in neuromuscular disease is children who are basically done growing, but not walking, sitting in wheelchairs. And in that situation, there's lots of different surgical options in terms of how long the fusion is, whether you need to go down to the pelvis, the kinds of implants that you use, the kind of materials that you use. This is the first x-ray that I showed the child with the congenital muscular dystrophy, and she was having issues, difficulty sitting. You can see how far she's leaning to the side, especially in that x-ray on the left. And that makes it harder for her to sit comfortably in her chair. And like a lot of kids with neuromuscular disease, she was very intellectually intact, and she really felt this. And so surgery really helped to improve the quality of her life. So in conclusion, this is all about collaborative care, working on prevention strategies, rehab, physical therapy, exercise, regular exercise is really key. And then clear communications about the risks and benefits of surgery for any specific and particular child. Are really key. And so I hope that you all learned a little bit, and I'm happy to take any questions that you have.
Wonderful. Thank you so much, Dr. Schulz. That was a wonderful presentation. As a reminder, if you have any questions for Dr. Schulz on his presentation, please go ahead and leverage the Q&A box, which is located at the bottom of your screen, and we'll get to as many questions as possible. And while we wait for some to come in, Dr. Schulz, I know I had a question just looking at, thanks for describing kind of how it works with scoliosis and that they've got those rods that can grow with them. When you showed that fracture image of the individual who had to have the rod or the nails put in, does that grow as well, or does that have to come out once the bone is secure again?
That's a great question. So no, that rod doesn't grow. We actually, it's interesting, we do have similar devices that are growing devices, just like for the spine, for a long bone like a femur or a tibia, that we use to lengthen bones in very specific situations. But that is just a stabilization device, so that holds the two parts of the bone in a stable and correctly aligned position. And once the bone heals together, then that device isn't really doing very much. They usually don't impair growth unless they are crossing a growth plate. And so they don't always have to be removed, but occasionally they are removed after healing is complete, for a variety of reasons, sometimes patient preference or comfort, or if you're worried you're going to have to do more surgery in the future. But that's not a growing device.
Okay, that makes sense. I think another question is around kind of the scoliosis surgery. Is bracing still something that comes into play following a surgery?
We prefer not to. So when people first started doing scoliosis surgery decades and decades ago, they didn't have the same kind of implants that we have now, the screws or the hooks or things like that, and the stability was not as strong in the early period. Then casting or bracing was utilized. But now, because the implants are so strong and powerful and really hold that spine in the position that we want, bracing is usually not necessary. And really the goal of that surgery is not to need a brace afterwards. However, I will say that occasionally in certain kids, especially really young kids who get surgery, if it's a growing surgery, then a short period of bracing after surgery can be helpful in order to give a little bit of extra protection to the surgery that you've done.
Okay, that makes sense. Well, Dr. Schulz, we greatly appreciate your time today and for presenting this wonderful information. Thanks for joining us.
Oh, my pleasure. Thank you so much.